30 years after identifying the virus that causes AIDS, the fight for a cure goes on. HIV remains the world's leading infectious killer, but a misconception is still shaping perceptions about the disease. This is Inside Story. Hello, welcome to the programme with me, David Foster. It is 30 years now since French researchers unmasked a global killer, HIV, the human immunodeficiency virus that causes AIDS. 3 decades on and much has been done to treat and to prevent the disease, but researchers believe a cure still may be years away. More than 60 million people worldwide are estimated to have been infected by HIV, and some 25 million people have died from illnesses related to the infection. 34 million people are living with HIV worldwide, but many have also lived with much more prejudice, discrimination, and even abuse. We'll go to my guests in a moment, but first let's hear from somebody who had first-hand experience of caring for somebody infected with HIV and AIDS. Richard Fairbrass was, and indeed still is, a member of the British cult band Right Said Fred. He's gay and free of HIV, but his partner for more than 25 years, Stuart Pantry, developed AIDS and was one of the first in Britain to undergo experimental drugs treatment in the early 1990s. He died of cancer in 2010 at the age of 45. Richard told me that things have come a long way since those early days.
Things have changed a lot, and what I think happened was it affected different levels of society in different ways. With regular people who were scared, everybody was scared, partly because we didn't know, nobody knew, and doctors didn't know exactly how this was transmitted. And so there was an awful lot of paranoia about, I remember I had a friend who worked as an aerobics teacher, and nobody would share aerobics mats because we weren't sure, people weren't sure whether it was passed on by perspiration, or they weren't sure if you shared a toothbrush, or if there are a number of, even airborne people were not sure of, and Stuart actually got sacked from BT at the time because nobody would use would share his computer keyboard. So it was a very fearful time.
Compare the attitudes from early 90s to 25 plus years later, when you and Stuart went out and you said, or came up in conversation, that Stuart had AIDS. How would people have reacted differently across those 25, 26 years? Well,
I think it's people tend not to use the expression AIDS so much now in the West, certainly, because there used to be that ghastly expression full-blown AIDS, as if there was something prior to that was okay. You don't hear that so much now. Attitudes are more relaxed about HIV because it is a more treatable condition. Having said that, it still kills people, and if there are anybody out there who thinks that HIV is fine because they can just take some tablets and it'll all somehow go away or be entirely manageable, that is still not the case. There are a lot of factors that will affect your health, whether you're multiple infections, a single infection, your overall health, whether you're a drug taker, whether you booze, late nights. There are all sorts of other issues around your the physical reality of the way you live that will affect your ability to fight HIV. It's not a good idea for anybody to imagine they can deal with this and with a happy outcome, because very often it's not. It's still a serious condition and a long-term condition. But people don't freak when they hear the word these days, do they? No, they don't. They don't. No, people understand how it's transmitted. There's not. Lady Di was a huge ambassador for that, and it takes people like that with real spine to cross that Rubicon, which has to happen in all sorts of areas, not just with HIV. It happens in all sorts of areas. But as we've seen recently in the UK, the gay issue is still a huge, huge issue for some people, and it is ironic. I think it mystifies
Richard,
me.
I know you promote AIDS awareness, and because you live with somebody who had HIV and AIDS, you're well aware of the drugs that are used. How closely do you follow the research now, and how far do you think we've come?
Well, we've come a huge. I can remember when Stuart was first, not when he was first diagnosed, but when he was very poorly in '96. His consultant came into his room, and he was discussing Stuart taking combination therapy, which was about 20 or 30 tablets a day. And the guy said to Stuart, he said, "If you don't take these tablets, I will never treat you again, because these tablets will save your life." So I was very aware, and I tended to do Stuart's Dosset box all the time. I went out and got the drugs, some of which were hugely expensive. When Stuart passed, which was 2 years ago, I remember the date, it was September the 20th, 2010, I stopped thinking about HIV, and I started thinking about him. I mean, that was the difference. When he was alive, him and HIV were wrapped up in a very complicated way for me, and I was always as any partner of somebody who's chronically sick will tell you, you have this weird place where 1 minute you're the partner, 1 minute you're the carer, and it's a very, very strange place that you find yourself. So I don't follow HIV research like I used to, obviously because Stuart's no longer with me. So I've taken a back seat on that a little bit, and partly for selfish reasons. I've tried to not forget it, but I've tried to find a place for it where it doesn't consume me like it did before.
Let's bring in our guest in Johannesburg, Helen Reese, who's Executive Director of the WITS Reproductive Health and HIV Institute, and joining us from Seattle, James Coughlan, who's Executive Director of the HIV Vaccine Trials Network. I'm going to go to you, Helen, in just a moment, but first to James in Seattle. You've been working on trying to find a cure for decades now. How close are you to either finding something that kills the virus or cures AIDS?
Well, actually, a cure for HIV is probably many years off, although there has been great progress in the past few years toward the development of a cure using multiple strategies. We are focused on a preventive HIV vaccine that could be used to immunize individuals who are at risk for acquiring HIV and enabling them to prevent an infection from being established after HIV exposure.
So some kind of inoculation is not that far away, but still only possibly.
That's right. We have several HIV vaccine clinical trials underway, and over the past 3 years there have been results that have shed light on how best to progress further for the development of an HIV vaccine that is applicable globally. And we're quite optimistic that with the studies that we have planned in the near future, that is in 2 to 3 years, we will gain the additional insights necessary to finally develop an effective HIV vaccine.
There are numerous headlines several times a year that say AIDS breakthrough. One of the ones that attracted a lot of attention was that baby in America that was given retrovirals almost the moment it was born, and was then found, even though it was probably infected with the HIV virus, it was found that the virus had gone. How exciting was something like that?
Well, that is exciting. There are other studies that have found cohorts of individuals who have been exposed to HIV, perhaps even transiently infected, but not persistently infected. And there's one individual notoriously called the Berlin patient, who also was cured from his HIV with a successful bone marrow transplant that he had to receive for a blood cancer. Now, these extraordinary measures are not the type of techniques or therapies that could be applied generally to a high-risk population. So we still think that an HIV vaccine is really the best way to control this global pandemic.
James, back with you in just a moment, and we will be off to Johannesburg in a couple of minutes. But before that, let's hear from Tanya Page, who is in Durban in South Africa, on how the tough economic climate is hurting the fight against the AIDS pandemic there.
Sinekitembe Clinic was once a renowned HIV/AIDS treatment centre with 15 doctors, 25 nurses and a first-rate reputation for providing quality healthcare to its 4,000 patients. But it was forced to close after funding cuts from an American initiative called PEPFAR, the President's Emergency Plan for AIDS Relief. Now patients like MK Mkezi have been transferred to government-funded healthcare facilities.
The new place doesn't check my blood every month. The last time was in January, but the move isn't as bad as I thought it would be. They give me all the medication except the multivitamins I'm supposed to take.
By 2017, the $500 million PEPFAR gives South Africa will be halved, prompting non-governmental organisations that rely on the fund to warn that as more clinics close, patients will suffer. This clinic's patients and workers, who have mostly been laid off, are the victims of the first round of funding cuts, a relatively small $20 million. But those cuts will increase over the next few years, so it's a race for the government to build enough capacity in the public healthcare system to cope. Durban's McCord Hospital has accepted some of the patients from Sinekitembe. Dr. Henry Sunpath says he's being very careful about how he spends the remaining funding.
The systems are a challenge because of the large number of patients in the public sector, people with advanced disease, and even now people with some complications and some failing biologically. So these have to be addressed. And so the target of the funding is mainly to create capacity in the healthcare institutions.
Health officials don't want patient care to suffer, but they are realistic about the challenges.
So we're trying to do everything we can to ensure uninterrupted supply of medication. But can I guarantee that every patient will get drugs every time they come to facility? I can't guarantee that, but clearly we're working hard to achieving that.
The PEPFAR funding cuts mean government has no choice but to cope as best it can. Otherwise, the great gains made in preventing and treating HIV/AIDS could be lost. Tanya Page, Al Jazeera, Durban, South Africa.
We go to Johannesburg. As promised, Helen Reese is waiting patiently for us. She's Executive Director of the Wits Reproductive Health and HIV Institute. Helen, those cuts, great strides, as Tanya was saying there, and some of the guests were saying, but it would appear that any of the good work that's been done could be undone by this cutting back in the amount of money available.
Yes, I mean, South Africa has indeed made enormous strides in terms of getting people onto treatment, and we've now got nearly 2 million people on treatment. And when we started, we just had tens of thousands through the private sector. So this has been an extraordinary achievement, and it has been supported in the past few years by the PEPFAR grant. But government is also very keen to step up to the plate and has already done this significantly in the public sector. I think what's important when grants are withdrawn and governments take over is that it's done in a very careful manner. Because clearly what we're dealing with here is people who are maintained on treatment, and we want to maintain them on treatment. We want to expand, in fact, the numbers of people on treatment. And if anything is done precipitously, then what it could mean is people's lives. But I must say that all parties are very aware of this. And the South African Treasury itself has committed more funds to the public sector to try and take up some of this slack. But that doesn't mean to say that this is going to be easy.
That it is easier now to get the drugs to the people who need them, because I was reading that whereas in the year 2000 it cost maybe $10,000 a year using certain drugs to treat one patient, now that has come down to perhaps $100 a year, making it much easier for people to get the treatment they need.
I think there are several things that have made it much easier. Certainly the cost was prohibitive when we started all those years ago to lobby for public sector rollout. The cost has come down dramatically. I think there's been really massive breakthroughs in the way the world views access to medicines and the costs of medicines for poor countries. And that, I think, is a stride in and of itself. It's not only the cost, though, that's increased access. We have a health minister who's been completely committed to pushing people to test, because with the stigma attached to HIV, a lot of people don't want to come forward for testing. once you offer people treatment, there's a reason to test. People feel more confident that something will be done if they test positive. And if you have more public debate and more public personalities coming out saying we're positive or my relative died of HIV, go and get tested. I think that all of these things together have really pushed us in the direction of easier access.
Well, we'll get onto the stigma and some of the changes in attitude, if we may, in just a moment. But first, let's take a look at the way it spreads around the world. Sub-Saharan Africa, we were talking about it there, accounts for more than 23 million of the 34 million or so reported infections. And South Africa, as we were pointing out, has got the highest number of any country at a little over 5.5 million. But the latest figures show a 50% reduction in the rate of new HIV infections in 25 low and middle-income countries over the past decade. And not all good news. The number of newly infected people has risen in the Middle East, North Africa, Eastern Europe and Central Asia. In Russia, for example, new infections increased by 50% from 40,000 in 2006 to 60,000 in 2011. James Coughlan in Seattle, as you look at possible cures, inoculations, means to eradicate this terrible virus, or at least control it. Are you worried when you see infections increasing in certain parts of the world, even though they are going down in others?
Oh, most definitely. And when we see the number of HIV infections increasing in many parts of the world, of course, this in part is a result of the great strides that have been made in the treatment for HIV. And that is, more people, of course, are living with HIV, but that incurs tremendous costs for maintaining these large numbers of people on treatment. It also may reflect a somewhat of a more passive approach or a complacent approach by some societies in the extent to which they hammer away hard at the message that's necessary for HIV prevention. And we've seen here in the U.S. an increase in HIV infection rates among young men who have sex with men, for example, and other demographics within the United States. And there's questions as to whether or not this is a result of some of these populations becoming more complacent about whether or not they're preventing HIV due to the widely available therapies that are, they have access to.
On that theme, tell us about a drug called Truvada.
Truvada has been demonstrated to be effective as a pre-exposure prophylaxis medicine among certain populations, mostly in the U.S. and the Americas. And that could be taken regularly, once a day, to potentially prevent acquisition of HIV. And it is licensed in the United States for that purpose.
So this is a drug that you can take, as I understand it, the day before and the day after you might be exposed to the HIV virus, and it pretty much eradicates the possibility of you catching it, which is great that you don't catch it, but it might encourage a certain laxness of attitude in a great number of people.
Well, that's correct, and we're just learning more about the use of Truvada and the willingness of individuals to use it appropriately, and that is in full compliance of a regular daily dose. And it is not 100% guarantee that individuals taking Truvada would not acquire HIV. So it is not foolproof by any means. It does require adherence and compliance to taking the drug. And you're right, there may be some disinhibition, as we refer to it, among those individuals who are taking the drug to expose themselves more frequently or rigorously to the HIV.
Helen Reese, when you think about the number of people you've encountered who have difficulties talking about AIDS and HIV, if you have something like Truvada, which means that you can basically take it and almost ignore the risks, there's a danger, would you not say, of enormous complacency?
Well, I think the first thing we've got to remember is that taking drugs for prevention of any sort requires an enormous amount of motivation. So far, our experiences of using antiretrovirals, the same categories of drugs, but for treatment, when people are highly motivated to take them, we just don't know enough about how different groups in the population would respond if they were offered to a drug that they'd have to take every day. Would they take it every day? Would they take it if you're a young woman when you're likely to see your boyfriend? Would you take it when you have a boyfriend and stop when you don't have a boyfriend, and vice versa, and so on? There are lots of unanswered questions about how PrEP would be used. But I think, overall, PrEP wouldn't just be handed out. It would be done with education. It would be done with the offering of condoms. It would be one of many things that we're still offering to try and reduce HIV infection. We're offering circumcision to young men. We're offering female condoms now for young women. So this would be part of a package of prevention, and it would require quite careful counselling. But there are pilots going on in the African region now, looking at different groups where they're at particularly high risk of HIV infection, such as men who have sex with men and sex worker populations, where we're starting to explore whether this would be an acceptable option and how it would be taken and whether people would adhere to the drug, because those are critical questions to ask.
Helen, there are two areas that I want to ask you about. One is mother-baby transmission, which was such a worry some time ago. I gather massive strides have been made in preventing that, or at least bringing the incidence down.
I mean, this has really been one of the biggest success stories in the last 10 years that we've seen. When we started off, if you take South Africa as an example, and there are many countries in East and Southern Africa where this would be true, as many as 1 in 3, and it's still the case, of young women who are pregnant are HIV infected. And of those women, about a third of them would transmit HIV to their infant in the absence of any intervention. So we started to introduce different regimens of antiretrovirals, and as we've got to understand better and better, we've now managed to, in many countries, bring down that 30% transmission rate to under 3%, which is absolutely remarkable. We're reducing transmission during pregnancy, during delivery, after delivery, and during breastfeeding. So this is a big breakthrough, and it's one, though, that we have to sustain. I think one of the questions you were raising earlier about maintaining grants for antiretrovirals, donor funding, it's incredibly important that we mustn't withdraw now thinking that we've made breakthroughs. Breakthroughs are strides in the way forward, but we have to keep the pressure on if we want to see the big reduction that we've seen so far in infected newborns.
When it comes to sex education, you may feel that you are making strides. I want to ask you about the transmission of AIDS via the use of drugs, dirty needles, etc. Is that a problem in Africa, or is that something that happens in the wider world rather than where you are?
Well, it hasn't been a major problem in terms of intravenous drug use, although Africa is part of the global world, and we are seeing an increase in use of IV drug use. But I think the bigger problem in the African region has been the other drugs. It's been the use of alcohol with sex and other drugs that people are using just to get high, where they're disinhibited and they have sex without careful consideration. So that has been a big problem. But the use of dirty needles and the increased risk that brings hasn't been a major issue here. But as you said earlier on, this is something that we're seeing as a major concern in Eastern Europe and in Russia and in countries where IV drug use is growingly common.
James, if somebody had said to you 30 years ago, when the HIV virus was first discovered, that in 2013 you still wouldn't be able to have found something to cure it or contain it properly, it would have been incredibly depressing. But do you still think strides are being made?
Absolutely. We've seen tremendous strides in treatment, not only for individuals, but also treatment as prevention. That is, individuals who are treated early in the course of their infection are much less likely to transmit to their partners or to others. And that's a critical application of the global effort to deploy the drugs for treatment, and as it will likely help prevent future HIV infections. And there have been strides in the past couple of years towards a highly effective HIV vaccine, which is really, we think, the end game in controlling the pandemic.
Well, we thank you very much indeed, and I'm sure along with us, there are millions of people wishing you the very best of luck. Thanks to James Coughlan there in Seattle. Also, many thanks to Helen Reese. Big thanks to Richard Fairbrass, who contributed to the show and wanted me to say that, yes, they are still touring, they are still recording. Thank you, too, for joining us. Don't forget, you can find this programme and many more at aljazeera.com. Just follow the links for programmes. Then find Inside Story. You can leave us your comments there too. From me, David Foster, and the rest of the Inside Story team. Thanks for watching. See you next time.